Okay, just a few housekeeping items. Welcome to our monthly UOCA meeting, everybody. We will be rolling out at the end of the month information about 2021 dues. At the end of April, we'll be locking down the training on the website, so you just have to have a password to get in to get access to that. Brad will be sending out an email to everyone to take a survey about in-person conference in this fall is what we're looking at, but we want some feedback from you guys to see if that's something that you'll be able to do or your jurisdiction will allow. So be looking for that email and please enter that or at least respond to that survey. This month's training, I have been very fortunate to get Dr. Ivey to come and present to us about hoarding. And Alsya Ivey has a doctorate in clinical psychology from Pacific University in Oregon. She also is an APA accredited, she attended an APA accredited internship from Orlando VA Medical. She is a licensed psychologist. She works at a treatment center at Lake Nona. Her specialties include insomnia, chronic pain, depression, anxiety, OCD, trauma and stress-related disorder. She heads a therapy group about hoarding disorder in Salem, Oregon. And I will also be forwarding more information about her in your monthly email. But let's welcome Dr. Ivey. We really appreciate hearing from you.
Thank you so much for that introduction. Can you all hear me okay?
Yes.
Awesome. Okay, yes. And you're able to see my screen. I am screen sharing as well, some slides for you with additional information. I do have a little bit of a disclaimer to start. I will need to leave about 10 minutes before the hour just to attend another appointment after this meeting today. But I really am looking forward to speaking with you all about hoarding disorder. This is one of my passions and I could go on and on about it, not just 1 hour, but it really took a lot to figure out like what would be the key pertinent information for you to take away from this. So I put together a few slides, but please feel free if you have questions for me, if you have access to the chat box on Zoom. While I'm presenting, I won't be able to see them, but perhaps the questions could be read out loud at various points too. There will be opportunity to ask questions at the end as well. So I'll be presenting today on hoarding disorder, gathering support for the individual and the community. So the objectives, I'll be covering some brief history and background on hoarding, basic definitions and diagnostic information about the disorder itself, factors that are associated with the onset of hoarding disorder and the maintenance of it, CBT, which stands for cognitive behavioral therapy, the conceptualization of hoarding disorder from that perspective, when to seek referral for treatment, and how to increase motivation, how to increase the individual's motivation to want to work on their hoarding. And then talk very briefly about some evidence-based treatment options that are out there. So let's take it way back in terms of historical context. So we know that hoarding's not new, right? And that human beings, we have a unique relationship between ourselves and our possessions. And this can range purely from utilitarian in terms of possessions having a useful purpose, all the way up to having possessions because there's a sentimental attachment or an emotional attachment to those possessions. We do know that the number of possessions owned by ordinary people has exploded over the past 50 years, probably more than that, largely due in our culture as a result of capitalism. In terms of hoarding disorder research, so a lot of this is brand new stuff. So clinical research within the last 20 years is really looking at hoarding disorder as being a condition that's distinct from OCD. So prior to 2013, previous editions of the Diagnostic and Statistical Manual of Mental Disorders classified hoarding as being a subtype of OCD. But recent research has shown that this is not the case and that actually hoarding warrants its own separate diagnosis due to underlying neuropsychological factors. So due to, research being fairly new, there really has been little previously known information about this phenomenon other than just anecdotes. So people sharing that they've had family members with this condition. And as a result, whenever it comes to light that this exists, it tends to evoke some very strong reactions when it's encountered. In terms of individuals who have hoarding disorder, this can lead to marked debilitation in their lives, and we'll talk about how it can affect them. Hoarding can be unhealthy or even lethal in some cases, and I'm sure you all are experts in this, but in terms of the health and fire hazards, the eviction rates, those kinds of things can all adversely impact someone who lives with this condition. As well, this condition can lead individuals to experience a great sense of guilt and shame, and this can lead to some secrecy. Other historical contexts, I'm not sure if anyone is familiar with the Collier brothers. So these were two individuals who existed in 1947. After their deaths, it was discovered that over 130 tons of material needed to be removed from their home. And there was so little of value amongst those items that it's recorded that their auction items fetched only about $1,000. Back then, that's probably a lot, but in terms of how much the quantity of belongings that was in the home, it's pretty significant. So packed was the home of Homer and Langley Collier that the interior was a maze of tunnels, and many booby traps were also in there, as Langley had a fear of intrusion into their space. So this garnered a lot of media attention at the time, following their death when this was uncovered. And this is one of the first instances in history where it got a lot of media attention. Nowadays, though, hoarding seems to be a more widely recognized phenomenon. So there are a lot of TV shows out there in the media like South Park, Hoarders Buried Alive, where it tends to show hoarding in a very, very negative light. And this can contribute to some stereotypes about hoarding. So how do we avoid some of those stereotypes? Well, some of the ones that exist are that individuals who have hoarding are lazy or that they're compromised in terms of their health and safety. But what we will learn is that this isn't always the case, and that it's important for us to look at each individual client as an individual and to recognize their strengths, and to also, as much as possible, avoid the use of stigmatizing language. So we tend to say that language, what we're aiming for is person-centered. So rather than talking about the person as being a hoarder, recognize that this is an individual that's living with that behavior. And so working with that person to choose some mutually agreed upon terms, and trying to avoid words like junk or trash to reflect what we're seeing, because that may not be how the individual refers to their belongings. Some additional diversity considerations. So I was going to have this be like a pop quiz question, but in terms of the prevalence of hoarding, we tend to think that perhaps that the phenomenon exists more often in women than men, but what the literature and the research shows is that hoarding disorder is actually more often diagnosed in males than females. However, in females, there can be more excessive acquisition. Also, it tends to be that in clinical populations, it might be heavily skewed toward females because women may be more likely to seek out treatment for the condition. Other diversity considerations to keep in mind are socioeconomic status. So past experiences of living in extreme poverty, how this can be associated with hoarding. How there can also be generational differences regarding consumerism and perceptions of material possessions. Also separate considerations for older adults. I have a separate slide on this next, but that there can be very much physical limitations being a barrier to decluttering efforts, and that also there can be increased danger in terms of fall risk for this population. We already discussed avoiding the use of stigmatizing language. In terms of other considerations for older adults, so there tends to be a greater prevalence rate among older adults, but we'll talk about the onset and the development of this condition momentarily. But in older adult populations, there tends to be greater severity of symptoms. Also, older adults with hoarding are more likely to be socially isolated and to live alone, and that these two factors can also be connected with depression. So we'll find that hoarding disorder often is comorbid or co-occurs with other kinds of mental health conditions, the number one being major depressive disorder, which is prevalent in over 50% of individuals who have hoarding. Also, there can be impairments in psychosocial functioning related to mobility, right? And this can contribute to increased danger in this age cohort. There are also legal and ethical considerations. So this is going to vary by state. And I'm sure you all are very familiar with your state's laws regarding how individuals who have hoarding, how this could pose potential risks if they do live with others. So I made sure to add in there that there is that duty to report child and elder abuse, and that this duty to report can vary by state, but that typically it's immediate report if there is reasonable cause to suspect that abuse, abandonment, or neglect is present. Also, states vary depending on reports for animal cruelty. So sometimes hoarding disorder can, animal hoarding can accompany that. So it's not just hoarding of possessions, but could include hoarding of animals as well. So I made sure to include the definition of that in terms of animal cruelty. Abandonment means to forsake an animal entirely or to neglect or refuse to provide or perform the legal obligations for care and support of an animal by its owner. In terms of prevalence and course. So the APA Statistical Manual of Mental Disorders says that hoarding disorder is thought to occur between 2 to 6% of the population. I suspect that that's an underestimate of the actual incidence of hoarding. It's just that it's possible that with samples and once more research comes to light, we may find that there is greater prevalence of this than we think there is. We already talked about the slight gender differences and how hoarding can be highly comorbid with other conditions. In terms of the development and course, so onset is believed to occur between the ages of 11 and 15. So this is a lot earlier than most people might expect. However, it's often not caught that early because hoarding behaviors are usually managed by third parties. So parents are picking up after the child. And so it may be less likely, for this to cause clinically significant distress and impairment at that age group. In the early 20s, hoarding behaviors might start to interfere with everyday functioning to some extent, perhaps when someone is going off to college and they have to share a room with a roommate, and those behaviors start to impair that relationship. And going on into early 30s, it can start to cause clinically significant distress and impairment as, in that developmental age range, the person may be starting a family and living with others, and it could be that could cause interference in their relationships if it is still not managed by the third party, like a partner, taking care of routine things in the home. But it's usually not until between the ages of 55 and up where the prevalence rates of hoarding triples, in the sense that they may end up, more often than not living alone the older they get, when friends and family members pass away. And if someone is living alone, they are far more likely to have this condition get to the extent where it's unmanageable. In terms of predisposition, individual family patterns, So those who hoard are more likely to be unmarried or divorced. Hoarding tends to run in families, so there can be a genetic component to this, but also keeping in line with that nature versus nurture debate. So it's not just nature or genetics, but nurture, the environment can play a role in terms of some of these behaviors perhaps being learned or modeled. Hoarding is also associated with unique neuropsychological activities. So we'll talk about how performance deficits can be measured on areas of planning, learning, sustained attention, and other information processing deficits in those who experience hoarding. More often than not, these individuals have difficulty with decision making, and this can be a major barrier to them being able to solve the problem once it gets out of hand. In terms of the DSM-5 criteria, so the DSM-5, this is like clinician's Bible. It's our diagnostic and statistical manual of mental disorders. This is how we make the diagnosis. These are the criteria for hoarding. And just as a reminder, the DSM-5 is a manual that was recently published in 2013. So this is the latest. Prior to 2013, hoarding was still considered to be a subset of OCD. And now it has its own separate criteria. So the first is a persistent difficulty discarding or parting with possessions regardless of their actual value. So it really does not matter how much something is worth, it's just that difficulty with discarding it. The criterion B, this difficulty is due to a perceived need to save the items and to distress associated with discarding that item. Criterion C, the difficulty discarding possessions results in the accumulation of possessions that congest and clutter active living areas. The key part here is that it substantially compromises these areas for their intended use. So this is probably what you're seeing when you enter individuals' homes, that there's lots of clutter and that it is compromising the room's use or that it's creating hazard. And then criterion D, the hoarding causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Depending on the individual's insight level, it may or may not cause them distress that they have this issue. That's important to keep in mind. But if it is causing impairment in the sense that they are at risk of eviction or it is unhealthy substandard living conditions, then this would still meet criterion D. In order to meet criteria for the diagnosis, hoarding symptoms cannot be attributed to another medical condition. So there are other organic medical conditions that can have hoarding as a symptom. And also the hoarding cannot be better explained by the symptoms of another mental disorder. In terms of the diagnosis, there can be additional specifiers that can accompany it. So an individual with hoarding disorder may also have excessive acquisition. So this is difficulty discarding possessions and through excessive acquisition of items. And these things are not needed and for which there is no available space. Insight level is also a specifier. So individuals can have good or fair or poor insight. And this can become a treatment enhancer or a treatment barrier. There can also be absent insight or delusional beliefs. This is often the case when somebody has a comorbid condition, such as psychosis. I do want to keep in mind that with that first specifier as well, with the excessive acquisition, that about 80 to 90% of individuals with hoarding disorder will have that excessive acquisition piece. So the most frequent form of this is excessive buying, followed by acquisition of free items. And stealing is less common, but is still a possibility as well. And so individuals who have the excessive acquisition specifier, they typically experience distress if they're unable or are prevented from acquiring items. So I just wanted to throw in a slide in here about animal hoarding as well, and just how this can be an additional risk factor. So we touched on it during the legal and ethical slide, but I do want to note that there are differences between animal and object hoarding in the extent to which condition may be more unsanitary, and that there is an association between poor insight level and those who have animal hoarding as part of their presentation. But what if somebody's like, I am just a collector, I am not a hoarder? So many people do acquire and save large collections of things. There is an inherent difference between saving and hoarding though, and that is in the degree of organization. And so individuals who have hoarding disorder, given that there are underlying cognitive deficits that can be associated with it, organization is a factor here. I apologize, had to mute myself for a moment. I am in a treatment facility, and so sometimes they announce patient names over the intercom. So I may mute myself periodically. So how does this happen? Insidiously over the course of months and years. So we talked about the development, how the onset typically shows itself between the ages of 11 to 15, but that it doesn't quite become impairing until later in life. So I like to use the analogy of a bathtub. So a bathtub collects water and is unable to drain. And so it will eventually overflow and could become lethal if you have anything plugged in or any electronics around. So same tends to be true about hoarding in terms of it becomes an issue when the acquisition piece and the discarding piece and removal of clutter is not addressed. So this is where treatment becomes important. I just wanted to briefly go over a cognitive behavioral model for hoarding in terms of how this condition develops. So hoarding is conceptualized to stem from 4 main deficits or problems. The first are problems in information processing. And so I have some examples in that top left-hand box there. There can be deficits in perception, memory, decision-making, categorization, attention, and these are all cognitive domains that can be assessed through neuropsychological assessments. And then the second deficit has to do with, or second problem, are emotional attachments to possessions. So there can be beliefs about their instrumental value, their intrinsic beauty, their sentimental value, and this can make it very difficult to discard. There can also be erroneous beliefs about the nature of possessions. So beliefs about vulnerability, that if they were to lose those things, there is a sense of loss or grief associated with that, or that their belongings give them a sense of safety or comfort. There can be beliefs about responsibility. This has to do with perhaps not wanting to discard items for fear of where they'll end up. Like they'll end up in a landfill somewhere. And so that can cause a lot of distress. Like I'm responsible for these items. I don't want them to end up in a landfill. There can be beliefs about memory. So not wanting to discard items because perhaps they are rooted to some memory in their lifetime, or the way in which these items are stored in their home, they may believe that they know where everything is, and that if these items were to be moved, that they may not be able to find them again. And so there can be distress related to memory. And also beliefs about control. So we'll talk about, in terms of recommendations when working with these individuals, control is a huge theme. And so whenever others are handling their items, it can result in a feeling of lack of control. So the fourth main problem is behavioral avoidance that can be associated. So any one of these beliefs and any one of these behaviors can lead to either positive or negative emotions. So you'll see that closer to the right-hand side on that diagram. Whenever somebody is acquiring items, it can lead to a lot of pleasurable feelings, right? Excitement, joy, happiness at acquiring something that they like, or that thrill of the purchase. But it could be that a lot of the negative emotions that are associated with this come as an after effect. So when their beliefs are being challenged, or whenever there is guilt and shame associated with having others enter the home, it can lead to other kinds of negative emotions like sadness and anger. But more often than not, the part that we see out of all of this, the visual part, is on the top right-hand side there, which is the clutter. That's what we see. But there's all this underneath that tip of the iceberg, considerations to keep in mind. So when it comes to treatment interventions, the things that we want to target first would be the acquisition and the difficulty discarding. Because I like to use the analogy of, you know, when you're shoveling snow from the driveway, and I live in Florida, but you all live in Utah, so you know snow. So if you are trying to shovel your driveway and it's still snowing, I have a feeling that you may not feel as if you're making a whole lot of progress. And that could be true for those individuals who are trying to sort through all their clutter. It's like if we haven't closed that tap of the acquisition, then more items are still going to be coming into the home, even as they're trying to get things out. So hopefully I clarified this enough. It looks kind of scary and intimidating, this diagram does, but. So when is treatment warranted? Look for these three main features. The accumulation and failure to discard a large number of possessions that appears limited in value to most people. Extensive clutter in living spaces that precludes activities for which the rooms were designed. We talked about this. This is probably what you're going to see first. And any significant distress or impairment resulting from hoarding. But just remember, depending on the individual's level of insight, they may not have any distress. And also if they have a comorbid mental health condition, that definitely we would want to get that other condition treated concurrently. Some helpful screening questions to ask. When you're working with individuals who struggle with hoarding, you can ask questions like, do you ever feel like you have too many possessions, but feel unable to decide what to discard? Do you ever find it difficult to access important areas of your house as a result of your possessions? Do you feel sad, anxious, or hopeless as a result of having too many possessions? Do you avoid letting friends and family in your living space because you don't want them to see? So asking questions like this, as long as that rapport is established with them, this can further build trust when you're working with them. And these questions are just suggestions as well. So, you know, thinking about what questions that you might employ based on your profession and your own unique style in your information gathering process. I want to share with you two helpful tools. The first is something called the Clutter Image Rating Scale. And I just want to open this up to the audience. Has anyone had exposure to this before? Oh, I see a couple of head nods. Okay. All right, so this is a helpful tool. We use this to assist with diagnosis, but I feel like this is a good interdisciplinary tool where others besides clinicians can use this to assess the situation. So the Clutter Image Rating Scale, I actually have this laminated, so it's awesome to just work with individuals to see what is their level of insight, but also to get a sense of, you know, whoever is entering the home, whether it's family members or other professionals, to get their sense of how they would rate the space. There are clutter image rating subscales for different rooms. So here on this presentation, I only included the one for the bedroom as an example, but there are also rating forms for the living room, the kitchen, the bathroom. And so what we are asking the individual to do is to rate how they view the clutter in their home. And then you can also put your own rating. What we would say is that any rating above a 4 is clinically significant. So if you do see homes that have a 4 or above, that this may be somebody who might benefit from clinical The homes is a second one I would like to share with you all. So this is a multidisciplinary hoarding risk assessment checklist. So I'm going to actually pause my slides for a moment so I can pull this up. So you can actually take a look at what this tool looks like. I would be happy to share any of these scales with you all as well. I can send them over in an email following this presentation. Can you all still see my screen? I have the PDF pulled up for the homes. Yes, awesome. Okay, so this is like a checklist. You can use this when you're entering the individual's home to assess these different domains. So homes is an acronym. The H stands for health. So whether or not somebody can use the bathtub or shower, can't access the toilet, the garbage or trash is overflowing, and you just check each of those sections. Whether or not there are any obstacles, like the individual themselves or you cannot move freely or safely throughout the home, and that this can pose a serious risk. For example, if EMT needed to enter the building, whether or not they could. Also, if things are stacked so high, if it creates an avalanche risk in terms of things potentially falling, and also whether or not egresses, exits, or vents are blocked or unusable. So this is very important too, and I'm sure all things that you all are looking out for when you're entering the homes. The M stands for mental health. So this is not that we would, be diagnosing them here, but we would be identifying risk factors. So does the individual seem to not understand the seriousness of their problem? Do they seem to not accept the likely consequences of this issue? Are they defensive or angry? Are they presenting as anxious or apprehensive? Are they unaware, not alert, or confused? These are all checks that may indicate some other intervention may be warranted. Also, the E in homes standing for endangerment. So evaluating the threat based on whether or not there are threats to the health or safety of children, minors, older adults, any individuals with disabilities, or the health and safety of animals. And then the S, evaluating the structure and safety of the home, which I'm sure you have more detailed assessments for that than here in the homes. But this is a nice, easy, quick checklist. And there's a second page here that breaks it down in terms of household composition, who is in the home, risk measurements. So does the person have imminent risk of harm to self or others? Are they under threat of eviction? Are they under the threat of condemnation, that establishment? Capacity measurements, and also a space to put in your post-assessment plan or referral if that's something that you're considering. So again, if you're interested in the homes or the clutter image rating scales, I can send those after this in an email. Going back to the PowerPoint here. All right, are my slides showing? Simple, thumbs up, it's good, okay. All right. Some helpful strategies. I cannot emphasize this enough, but empathy. So I actually have a pin on my key ring here, and the pin says you have a superpower, and it's called empathy. So individuals who have hoarding, they are often very wary to let outside individuals into their homes due to the shame and embarrassment that can be accompanied with it. They may have even waited years to get help as a result. So being empathic to their struggles, this helps to ease their anxiety and builds rapport with them. Respect for the individual's property. These individuals have kept their property and possessions for a reason, even if it may not make sense to us. So respecting their property would include not touching anything without their permission, not assuming their property is trash. Just because it looks like trash to you doesn't mean that they themselves consider it to be trash. And collaborating with them on goals. See what they feel is most important to work on and start from there. So collaboration is also super helpful. I say multidisciplinary here because we want to get lots of people involved to assist them. And patience. So compulsive hoarding, this behavioral pattern has been in place for a long time in the person's life usually. And so it may take a long time to reverse it. Practicing patience, especially at the beginning, is imperative in order to build that relationship and rapport and to actually motivate them to seek help and treatment. And I do recognize too that although patience is important, we have to begin somewhere and at some point, right? So there's that trade-off, understanding the difference between starting slow and avoidance versus like, we need to do something about the situation because it is still urgent. And then also don't be afraid to make a referral. I just wanted to give, I'm taking a look at time here. I want to make sure there's ample time for questions and comments at the end. But just to give you a peek into what treatment for hoarding disorder might look like. So the most studied approach for hoarding disorder is cognitive behavioral therapy. That's been the one to have the most research supporting its efficacy. The general themes would be enhancing motivation and education about hoarding with the individual who struggles with it. Reducing acquisition, training them in organizational skills. So remember that there can be underlying cognitive deficits that can impair their ability to be organized. So we would try to help them learn some strategies for how to improve their organization skills. Also training in decision-making, and cognitive restructuring of those hoarding related beliefs. So remember, from that model I showed you earlier, there can be a whole lot of different types of beliefs related to items' usefulness, their responsibility, the sentimental value. And in treatment, we would be, working through each of those beliefs and challenging the ones that may not be the most rational. And we would also use exposure and response prevention techniques in order to help the person not avoid the tasks of working through the clutter and discarding. Also, if you feel that, a referral for mental health is appropriate, you can start that conversation early and ask them, what do they expect from treatment? They might have fears about seeking treatment. And so in terms of what can be done, evaluation and planning, strategic interventions, and relapse prevention. So the overarching goal of treatment is that we want to prevent this from happening to the person again in the future. This is why strategies like muck outs, where they just clean out a whole space and put the individual back into the space, is not always the best long-term solution, because we haven't solved the difficulty with the non-acquiring, and we haven't worked through that difficulty discarding piece. So then it's more likely than not that the individual will relapse and go right back to that previous behavior as a way of coping with stress. Other barriers of treatment to look out for. So treatment for hoarding is often not self-initiated. So oftentimes when we see people come to treatment for hoarding, it's not the hoarding that they want to work on, it's the comorbid conditions. It's the depression, or it's the anxiety, or it's the ADHD that they may have in addition to hoarding. And then it comes to light later that this is another issue that they have. Refusal and dropout can be very common. It's a lot of work. It's extremely taxing on the individual, and then physically, emotionally, spiritually, psychologically, all of it. And so individuals will tend to avoid and drop out of treatment if that motivation isn't targeted. Also, this condition tends to be more resistant to medications. That can, for the clinicians, that's often a difficult barrier to tackle. But we want to meet the person where they're at. And so in terms of their goals, if their goal is, I want to be able to have, friends and family in the home again, then making them visualize that. Go back to your goal. What is it that you want out of this? Because I'm sure they do not want to live under the threat of eviction their whole lives. In terms of enhancing motivation, noting that the person needs to know that it's possible, because sometimes the extent of the clutter is so vast that sometimes it feels like change is not possible for them. So instilling that sense of hope that they can change. And then I already discussed that in terms of helping them to visualize what life could be like without that condition becoming a barrier. In terms of other ways of addressing impediments to motivation, so friends and family, this can be a support, but also can be a hindrance. So that's something to keep in mind too, that if their social support is strong, we would want friend and family involvement, because often these are going to be the individuals that will be helping the person to engage in decluttering. But sometimes their relationships with others can be strained. And so asking those questions and respecting if they do not want others involved in helping them. Depression. So remember, if there are any comorbid conditions with the hoarding, we definitely want them to be seeking treatment so that those underlying conditions can also be treated, because if we alleviate symptoms of depression, they may have more energy and more motivation to tackle the issue. And of course, if the person lives alone, that can be a big barrier to motivation, because it's just overwhelming, this idea I have to do this all by myself. So I included this diagram to show, let's meet them where they're at, and sometimes that will require using those motivational interviewing techniques. Other strategies for enhancing motivation, so using open-ended questions with the person. How did this develop? When? What? Using reflective listening, so not only shooting them with questions, but also repeating, rephrasing, paraphrasing their feelings and thoughts that they share with you. And that can help build that relationship and trust. Using summarizing statements, affirming their strengths, informing and advising, and avoid arguing, blaming, or taking on a role of the expert with them. Try to meet them where they're at. I have a whole slide here in terms of other recommendations in terms of communities seeking to implement a case management approach to hoarding intervention in order to effectively manage the costs and to keep community members safe. This is a whole list of recommendations here, and I can include this in the email that I send as well with the other tools that were discussed. But I want to highlight the last bullet point here. Extending time standards for court cases where hoarding is the primary cause for eviction as a reasonable accommodation. I have worked with individuals with hoarding in the past who may need additional time to sort through and seek treatment for this condition. And when it comes to the threat of eviction, you know, sometimes it's like they get that posted notice on their door and they have a very, very short window to do something about this. And so where this is allowed, you know, as a reasonable accommodation, working with the individual to try to extend time standards where appropriate. I don't know how realistic this is in your line of work and where you are in Utah, but just something to keep in mind. In terms of discouraged approaches, so most of these we covered already. Not arguing with the individual about what they should or shouldn't discard or acquire, not taking over their decision making, not touching or moving anything without their permission, not telling them how they should feel, and also not working beyond your own tolerance level. Because I think, you know, this isn't talked about enough, but as professionals, how we ourselves can experience burnout, you know, other individuals' conditions, and the extent to what they go through vicariously, we could pick up on some of that. So definitely taking care of oneself is important. I have a slide here with additional resources too. I'll include this in the email as well. If you're curious and want to check out these websites and for more information, very helpful, especially the International OCD Foundation. The measures that I will be sharing with you, I believe can also be obtained from that website. And the mutual support website is also a good one. So I have some of my own questions for you all and to engage in some discussion, because I'm very curious and want to learn more from you. But I'm also open to any and all questions that you have for me. So feel free to chime in.
Well, I don't know about any other jurisdictions, but for mine, we usually come across properties where the hoarding is so extreme it's spilled out into the exterior of the property. I know for my jurisdiction, I have problems with what I can and can't do when the property owner lives there is it's not a rental and they're choosing to live in that manner. Here in Utah, we're very limited on what action we can take. So I guess I'm just trying to think of what our best practices would be for that situation.
Mm-hmm. I hear you that a lot of times these situations, by the time it gets to you, it is a way more urgent situation and that it's very time limited. So I recognize the need for us all to come together to support those who hoard and take that multidisciplinary approach, because it is a public health risk and it does affect the community system as well as the individual.
I guess my question would be, who should we report this to first? The health department here in Tooele seems to be only inside the home would they do anything about it. And I don't go inside the houses, but you can obviously tell from the stories that they go on or when you're at the property looking in the window, stuff like that. I'm just wondering what proper channels we need to take, I guess.
So this may vary state by state, but I do think that going back to the law, which talks about, is this posing a risk to the safety of the individual or others, especially if they're from a more vulnerable population, like older adults or those with disabilities or children, that it is super, super important that we do immediately report this to abuse hotlines. In Florida, we have a central abuse hotline. So one number to call for all of those things. But in terms of who specifically to report, you had said the health department. Is that something that you all have been doing already, reporting to the health department?
I've tried in the past, but like I said, if I'm not actually in the home experiencing all that stuff, they usually won't come look at it. And most of the time, I don't know if it's the same for everybody else, but we don't go inside the houses.
Mm-hmm. That's the difficult thing, because there isn't really a go-to person on who to report, is my short answer. There is only a go-to who to report to if a law is being broken, which would be, if there is a threat and a duty to report on abuse. Let me check I think I see some comments in the chat box, so one moment here. Oh, here we go. Okay. Feel free to utilize that as well if you have questions or comments.
I just had one other question. I assume you see two types of people, those who want to resolve this issue in their lives and those who don't. What's your success rate with each of those groups?
So the ones who are more motivated, those are the ones who I see, have the best treatment outcomes. It's very, very difficult for those who have the lower insight levels, because more often than not, they aren't coming to treatment in the first place. And so I wouldn't be seeing them, if that makes any sense. So yes, I tend to work with those that have more motivation, and just so that you all have more information about where I am now. So I currently work at the Domiciliary Residential Rehabilitation Treatment Center of the Orlando VA Medical Center. So I work with veterans, and oftentimes they come in with a whole range of psychosocial issues, and homelessness can be a part of that. And so some of them have homelessness histories that started based off of evictions due to, unsafe living conditions and hoarding. And so by the time I see them, they've gotten to a point where they don't have anything. Like, they have the clothes on their back, they've lost it all. And so that in itself is a super traumatic experience. So we are really, really then just starting at the basic hierarchy of needs here, just trying to help them, rebuild. But yet not go back to what brought them here in the first place. So treatment tends to be a lifelong journey in that case. And so, that's what oftentimes is so intimidating to the person, is that they don't like the idea of, like, what if I am in treatment for the rest of my life? But for those who are motivated, what I hear them say the most is that I don't want my children or my spouse or whoever after I die to have to take care of all this stuff. So they're already asking these really deep existential questions of like, what is going to happen to their stuff after they pass? And so that is a great place to start in treatment, which is that like, well, let's do something about it then, so that it doesn't get to that point where it's like you are the main character of your story, or you have more control over this than you think you do. Oh, I see a question or a comment here. Should we refer individuals to an OCD psychologist, or is there a better specialist to refer people to? So great question, because remember, hoarding disorder previously was thought to be a subset of OCD. So there are a lot of individuals who specialize in OCD who are equipped to treat hoarding, because a lot of the interventions are similar, especially if they're cognitive behavioral interventions, where OCD specialists do a lot of exposure and response prevention, which is one of the treatments for hoarding. So yes, you can refer them to an OCD specialist. And I do recommend that if there is, if the psychologist or other mental health professional does not specialize in hoarding specifically, because it's a lot harder to find those kinds of specialists. Any other questions or comments? I'm going to pull my questions back up too, just some food for thought and maybe something to reflect on after today. And you don't have to answer this here now, but I do want to say, I thank you all for this opportunity to speak with you. And I'm really excited to hear that you are interested in meeting the person where they're at and learning more about this condition, because at the end of the day, they are human beings and we are human beings. And I think that we can really create good, positive change in others' lives. And I know that you all are doing excellent work in that area. So thank you all for what you do.
Thank you, Dr. Ivey, so much. If you want to go ahead and forward me the slides to my email, I'll make sure that it gets posted where everyone can access it. And I know you have another meeting you have to get to, so we do appreciate your time so very much. Thank you.
Thank you so much. And again, if you want to reach out for consultation purposes in the future, I'll also make sure to give my email and my VA cell phone number so that any of you can reach out to me at any time with additional questions.
Thank you. Thank you so very much.
Have a great rest of your day.
Thank you.
Okay, thanks everyone. We will see you next month.
Thanks.